Hello, and welcome to the professional webinar for the Christopher and Dana Reeve Paralysis Foundation. I am Nurse Linda for the foundation, and I think many of you people listening already know me. So I say welcome to our listeners that we have all the time, and welcome to people that might be listening for the first time today. Well, let me describe myself. I am a lightly pigmented skinned woman of upper middle age, let's just say, put it that way, with brown hair with silver streaks that I have earned every one of them. I wear pink rimmed glasses, and today I have on a black turtleneck. So I kind of blend in with the background here. Um, I wanted to tell you that I know a lot of you have written in questions for today. Today, we're going to be focusing on spinal surgeries and things that go on inside your body while you're having surgery and all that, what happens in that process. So, we're just going to be answering the questions about surgery today. But know that your questions will be answered at the end of the month at the Ask Linda webinar, which is the last Wednesday of the month at 2 p.m. Central. So we will get to all of your questions. Also, know that these recordings are captured and are available on YouTube. So if you didn't get to see today, or if you want to go back, or if you want to look at any of our past presentations, you can go to the Christopher and Dana Reeve Foundation YouTube channel, Nurse Linda, and everything is on there. Like, I don't know, it seems like thousands of recordings now. We're going to have a presentation today. Some of the slides will be graphic. They're still pictures, but they do show internal body parts, and there is blood on the screen. So just know that, that will be coming. So if you want to look away, you can look away. But today I'd like to introduce Dr. Rex Marco, who is a spine surgeon. And I'm going to let you introduce yourself, describe and introduce yourself. Let me just say, he is a very fond member of the Reeve Foundation as well.
Hi, it's great to be here, and I'd like to describe myself. I have brown hair, and I'm wearing dark sunglasses, and I have a sip and puff driver as well as a mouse in front of me that I use with my mouse to control my computer settings. And I'm a musculoskeletal oncologist, which means I take care of bone and soft tissue tumors of the extremities and pelvis and spine. And I'm a spine surgeon. And I live with C2 quadriplegia. I have an incomplete injury, and I was injured in a mountain bike accident. I began my career in medicine. I always knew I wanted to be a surgeon since middle school, and I started off as a head and neck surgery resident, and then I changed to orthopedic surgery because I wanted to learn how to take care of people on the mountain in case they were injured. And I became more fascinated with orthopedic surgery in that training part of my career. And then in my training as an orthopedic surgeon, I realized that I missed taking care of people that I could directly impact and save their lives. So I chose to study musculoskeletal oncology. And I also realized that there was no one with specialized training in bone tumors and spine surgery. So I decided to also subspecialize in spine surgery. And now I'm going to go ahead and start this presentation on um, what is inside of me. So, spinal cord injury and the surgical treatment and what happened inside of my body. And I'd really like to thank Linda for this really interesting uh, topic she gave me because I I always know what's inside of me and knew what was inside of me and never thought that other people might want to know that. Next
And a lot
slide.
of people do.
May I have the next slide?
So sorry, I'm trying.
One of the questions that people might want to know is when do you decide to operate? And I think that's a great question. And what I like to look at first is, does the spine pass the test? Where the acronym PASS stands for, is the spinal canal patent? Is the spinal column aligned? Is the spinal column supported in the front? And is it stabilized in the back? So there will hopefully be an image coming up soon that shows the spinal cord compressed by broken bones in the front. The broken bones in the front are called the vertebral body, and they can push backwards into the spinal canal and push on the spinal cord, and that leaves the spinal canal not patent. Should we wait or keep going?
So
Oh,
sorry. We practiced this.
yeah, this is the way that technology goes. It worked perfectly in practice, and now here we are. But oh, I see it's coming. So I know some people have. I'm going to ask Dr. Marco put a little off off our scheduled questions, but I know a lot of people are very nervous about, they're going to have this surgery on their spinal cord. And so people are always surprised, especially in the higher level spinal cord injuries, when they have to have a surgery on their neck area. And they're always surprised to find that the surgery is done from the front of the neck instead of at the back of the neck. And so, can you explain maybe why that is? Why the entry is, in the lower back, people operate on the back side of the body, but up in the neck, they get a lot of surgeries through the front of their neck. So, what makes that difference?
Yeah, that's a great question. The historically, the operations in the neck were primarily done from the back as well, or from the front and the back. But the front of the neck is easier, it's easier to get to the spine and decompress the spine uh, when the fragments of bone are pushing into the spinal canal. It's easier to get there from the front, and it's easier to position a patient, and it's a some people believe it's an easier recovery if the operation's done from the front. And so more and more operations are being done from the front. Having said that, with recent data on some research studies showing that a bigger operation from the back called a laminectomy to decompress and open up the spinal canal may lead to more improvement of the decompression. So more and more operations are being done from the back than uh, what we may have seen in the last decade before this. You might want to maybe, if it's still not advancing,
Yeah, it's still not advancing.
um, we could go back to the PowerPoint and not go in presentation mode and just go and stay in this mode and click on the mm, yeah, just yeah, exactly.
Okay. Sorry about this.
So everyone can see that. And so there you see the broken bones and in the front, and those broken bones are pushing back into the spinal canal and pushing on the spinal cord. So the spinal canal is not patent. In this situation, the spinal vertebral column is aligned, but it's not supported anteriorly because those bones are broken. And in this situation, it is relatively stable posteriorly. The other thing that we look at once we evaluate the films is if we may or may not think an operation is in your best interest, we might put you in a brace and have you move around, sit up, walk around, and if you are stable, meaning you don't have any progressive deformity or loss of neurologic function, and your pain is controlled under normal physiologic conditions, moving around, then we consider you stable. But if you are having progressive deformity or neurologic compromise or pain that's not controlled in the brace or with non-operative interventions, then we consider you unstable and sometimes offer you surgery then. And then the other reason to consider surgery is to increase your mobility so that you can better perform and better participate in rehabilitation. Next slide. If you look at the image on the left, that's a CT scan, and the arrows are pointing to the spinal canal, and that's a normal spinal canal. The image on the right is of a patient I took care of where the bones from the front shot back into the spinal canal and caused severe canal compromise and took up all the space where the nerves and spinal cord and spinal nerves were before. And what we did for this patient is as follows. Next slide. You can first, I'll show you that we saw that it wasn't patent. And when you look at the arrows on the front of this illustration, you see that the spine was compressed and that bone in the front is wedge shaped. And so there was not normal alignment here. And since it was smashed in the front, it was not supported anteriorly. And there was damage to the structures in the back. So it wasn't stabilized posteriorly. So before the surgery, this patient's spine did not pass the test. And so what we did is we put in these long pins, which we call screws, and they're made out of titanium. And we put them above and below the injury. And then we performed a laminectomy, which is taking off that bone in the back, which you can see by that large arrow, to decompress the spine and create a more patent spinal canal. And then, next slide, we put rods to connect those brackets to those screws, and we used those rods to help recreate the normal alignment so that it's no longer wedge shaped in the front. It's more like a square again. In this situation, we were able to further support the spinal column by putting cement in the front of the spine where it was broken and then tightened the rods to the screws. Now the next slide is graphic, so you might want to turn away. Next slide, or close your eyes. So this is a patient who had cancer in their spine and spinal cord compression. And without surgery, they would have developed paralysis. So we started off with a laminectomy from the back of the spine, and this is between in the upper back and at the lower end of the neck. And we took the lamina off, and you can see the nerve sac with the nerve roots coming off of the nerve sac. And that helps decompress the spine and helped us get the tumor out. And then we connected the spine above and the spine below to each other with rods. And those rods were connected to titanium screws in the rest of the spine, above and below.
Dr.
Next
Marco,
slide.
there's a question about how big those screws are.
Oh, they're pretty big. So the ones in the lower the ones at the bottom here are about 1 inch, and the ones that we showed you earlier are almost 2 inches
It's pretty big.
long. Yeah, they're pretty big. And they look like screws you can get from Home Depot, but they're made out of titanium and they have some extra parts to them. Next slide. So those were examples of a laminectomy and some of the screws that you may have in your body. This is someone who had another injury in the lumbar spine, and they you can see that the vertebral body is broken and split, and there's bone fragments in the spinal canal. And what we did here was we put a titanium mesh cage in place of that broken bone to help support the bone in the front of the spine. Next slide. And this is what that titanium mesh cage looks like. Companies have realized that if they make them fancy colors, then the scrub technicians like those colors, so they're more likely to want us to use those kinds. So that's why they're these really nice colors. And then we helped further stabilize the spine in the front in this patient with some screws and a rod. The next picture will be also graphic. Next slide. And this is a patient who had a malignant tumor in their spine. And this was in the front of the lumbar spine. And if we didn't take it out, they would have developed paralysis. So we were able to take the tumor out, and that's called a corpectomy, which, see, corp is body. So if we take out the body of the vertebra, then that's a corpectomy. And you can see the front of the nerve sac here because the body of the vertebra is in the front of the spine, unlike a laminectomy, which is removing the bone in the back of the spine. When we showed you the nerve sac in the other picture, that was the nerve sac from the back of the spine. Next slide. So you've seen posterior, which is the back, spinal instrumentation, which are the screws and rods. You've seen the laminectomy. You've seen the corpectomy. You've seen anterior spinal instrumentation, which is the front of the spine. And you've seen a mesh cage in the front of the spine. And this picture is something called a laminoplasty, which instead of taking the bone off of the back of the spine, we create a trough on one side and a bone hinge on the other, and we lift up the bone on that hinge and give the spinal cord more room. And this is what more and more people are doing in the setting of something called central cord syndrome, which is an injury in the cervical spine. And you can develop a spinal cord injury from many people have arthritis before this kind of fall, which could be as benign as falling in your bathroom, for example. Some people have had that happen. And it's probably the most common spinal cord injury, uh, is central cord syndrome. And a more chronic spinal cord injury is something called myelopathy, which we don't talk about much, uh, but it is probably the most common form of spinal cord injury. And there was a question in the questions we received about when is there going to be a cure? And I think that there probably is a cure for many patients with myelopathy or spinal cord injury related to central cord syndrome who might have myelopathy and then fall and develop central cord syndrome and that kind of spinal cord injury. And when we combine that with early surgery, with or without the use of the ARC-EX system, which was another question we got before the webinar. Uh, the ARC-EX system is a transcutaneous, which means it's sticky pads put on your skin, spinal cord stimulation, electrical stimulation, and I, with the, I believe that with the research that we have using that device, and the dramatic improvements in function and strength that we are seeing, that I think many people with central cord syndrome or myelopathy may see such drastic improvements that they will feel like they are cured from their spinal cord injury. And the question that we also received is, when will that device be available in the US? And it already is available in the US and will hopefully be in more and more centers. Next slide.
Dr. Marco, could I ask you a question about what you just said about people with a central cord using the ARC-EX? Do you think that that would work for people who've been like had a central cord injury like 10 or 20 years ago? Would that be applicable to them, or is that only applicable to new injuries?
The Uplift trial, the the ARC-EX system was tested in patients who were injured as long ago as 32 years.
Wow.
And one person I know who was injured over 30 years ago and was part of that trial, he could not hold a cup or jug of water um, unless he was palming it between his wrists. And after the using the ARC-EX, he was able to grasp a 3 pound jug of water and bring it to himself from his table when I was eating dinner with him. And this was a year after his injury, or I'm sorry, a year after he had participated in the trial. So it, he had a long-standing injury, and it seems like it's durable even after not using the ARC-EX system. Next slide. It is possible that some people may develop something called a syrinx, and those red arrows are pointing at a syrinx, which is a fluid-filled structure within the spinal cord, and that white area is the fluid, and the gray above it is the spinal cord, and that white fluid is not normal. And some people have no symptoms related to their syrinx, but other people might develop neurologic deficits or spinal deformity or pain. And if that's the case, you may be a candidate for a shunt to be placed in your syrinx or correction of your deformity to take off the pressure that's pushing on that area, helping to create a stimulus for the syrinx formation. The next slide will show you how a shunt is put in, and in the upper left image, you'll see the spinal sac is opened up and held open with those threads. And then down on the lower left image, a hole, a cut is made in the spinal cord in the midline so as not to damage any of the functional neurologic elements that you may have. They go right in the middle, and then the fluid is drained out, and through that little cut in the spinal cord, that white tube in the upper right image is placed into the substance of where that fluid was for that was holding the was within the syrinx, and then it's sealed up again, and that tube will continue to drain the fluid that tends to collect in the spinal cord in these situations. Next slide. Some of you may have discussed with your doctors the placement of a baclofen pump for treatment of spasms. And this is an image of a baclofen pump. The pump is put under the skin in your abdomen, which is in the front of your body. And then that white tube carries medicine, the baclofen, from that pump, and it's tunneled under the skin and placed in the nerve sac outside of the spinal cord. And it releases lower doses of baclofen to the spinal cord to help control spasms so that you don't have to take as much medicine orally to control your spasms. And that can help with uh, CNS symptoms like sadness or sleepiness. I know I felt really sleepy, and one time I was on a dose that felt I needed to go higher to control my spasms, and I couldn't stay awake, and I didn't couldn't feel any happiness at that dose. So once I got my baclofen pump, my spasms were better controlled. I was more alert, and I could experience happiness again. And so for me, it has been great, but it's not for everyone. I know that. Next slide. And something that very few people talk about, but most people I know with spinal cord injury do have anxiety and did have anxiety before their surgery or after their accident, before their surgery and after their surgery. So, for me, one of the questions was asked was, what's something that I do or I recommend daily to do and to help me with my anxiety? I practice mindfulness, and I've been involved with the 12-step recovery program, and the combination of mindfulness and 12-step recovery program really helps me with my anxiety, uh, helps me find meaning and purpose in my life. And I think the combination of both of them decreases stress and is shown to increase resilience and improve health and happiness. Next slide. There's a question about what to look out for if we are going to have surgery. And some things that are controllable on our part are listed at the beginning here. And making sure that your glucose levels are okay if you have a predisposition to diabetes or prediabetes, and then stopping use of tobacco will help wounds heal and bones heal together. If possible, stopping the use of opioids can help with pain control afterwards, in my experience. And then it's really important for your surgeon and anesthesiologist to know that if you do have a CPAP, one moment, for sleep apnea. And then other things that most of us are aware of and acutely aware of is taking care of our skin and doing our best to do that. We did get a question about pressure ulcers and what's the best dressing, and those are hard questions to answer. And my doctor recommended something called Allevin, Allevyn, which was useful for the ulcers that I had. What I strongly recommend is that you really consider going on bed rest if you do develop a pressure wound or pressure injury. And if you have a persistent injury, have your doctor look and make sure that there's no bone exposed or no bone involvement. Because if there is bone involvement, then in my experience, it's been important to remove that bone, get soft tissue coverage, and make sure that our patients stay off of it. And I know it's miserable and extremely inconvenient to be at bed rest, and a pressure injury with an open sore can get worse and worse, as we saw from some of the questions we received before the webinar. UTIs and autonomic dysreflexia, I think Nurse Linda really addresses those well, and it's important to let your surgeons know about any infections you might have and what triggers for dysreflexia you might have. Next slide. And afterwards, you know, managing your pain and spasticity, letting your doctors know how much opioid medication you're on, what other SSRIs, and how much baclofen you're on. All of those things are really important in advocating for yourself about protecting your skin, and will you need an ICU stay, and when can you start rehabilitation. All of those things are really important to talk to your doctors about in the post-op period. I'd like to open up the webinar to questions now.
Okay, we have a load of them that have come in as you were speaking. So, going back to the syrinx, if the syrinx is old, does surgery become a non-option?
I don't know that answer. I'm I'm an orthopedic spine surgeon, and I wasn't trained to operate on the syrinx. So my neurosurgery colleagues uh, have more information on that. So I would recommend talking to your neurosurgeon about that.
Um, the next one is, talking about the ARC-EX. The someone would like to know, could this also work at the thoracic level of injury?
We don't have any publications on that yet. I'm I believe it will. And so we are studying, or the company is now studying its use in for bowel and bladder management And I think that they're going to find uh, positive results from in the thoracic as well as for bowel and bladder function. But we don't know that.
Well, I know a couple of people who have tried it in that regard in an experimental setting, with the company, but in not for public use, but for experimental. And they have had some uh not I won't call it return of function, but they've had some feelings in their brain that indicate that they need to empty their bladder or empty their bowel. But it's not like, and again, we're talking about just a handful of people, if even that many, but it's not like a sensation in your brain like you had before when you had to go to the bathroom, but it's a different kind of sensation. And so the question is, and maybe they've resolved this now, I don't know, but the last thing I heard about it was that a sensation that you needed to toilet, or was that just a little hint of autonomic dysreflexia, which you don't want to use as your gauge to have to an autonomic dysreflexia episode, even if it's a mild one. So there's still a lot to be worked out on that. As I say, this is only from like talking to a couple of different people, but I think my point is there's hope out there that this will be successful. And we're all rooting for it. So, as I always like to say, will it be like before you had your injury or before your disease changed your sensation? No, it's not going to be like that. But will it be an improvement in what you have? Yes, it's just different. Let's see, we already answered the question about how big the screws are. Oh, and this question, and I know that Dr. Marco, you're going to have some thoughts about this. Is there a reputable resource to research stim devices for spinal cord injuries, T4 through T6? Do you know about any one source or a variety of sources so that people can pick and choose?
Hmm. Well, probably the most reputable source is PubMed, and you could do searches on that, and you could. I actually like some of the AI resources, like ChatGPT, for example. They're I found them surprisingly helpful and accurate, and that was another question we got about advocacy. How do we work with when we feel there's medical ableism or we need to advocate for ourselves uh, in the medical system? And I think that it depends on if it's a someone who works in the clinic or the hospital, if they are a nurse or therapist or nursing assistant or the clerk, then I would advocate for yourself with their supervisor. And if it's a doctor, then I would consider advocating for yourself through the administration of the hospital or the place they work. And then you could even advocate for yourself online. Google and Yelp reviews they may not feel like they're noticed, but they are not unnoticed. And then you can also advocate for yourself if there are issues with a doctor, with the state board. And in all of those instances, I think I have found that ChatGPT, if you tell Chat what you're thinking about saying and what happened and what you're thinking about saying, it can help guide you in a calmer way that may get your point across. And then, of course, with doctors and even other healthcare professionals, you can always also advocate for yourself through the legal system. And I found chat very helpful in that situation. I'm sure Gemini and other resources are also helpful for advocating.
I have to agree with you on that. Those are good resources. Um, I
But
had
I
some
may
thought.
not have answered the other, sorry, I just may not have answered the why I got off on talking about ChatGPT is that it's also a good resource to figure out more information on different devices that or research that you may be interested in finding out more about. And then you can check those ChatGPT references on PubMed. And then
Yeah,
when you do get an article from PubMed, you can copy it and paste it in your favorite AI resource and it will translate it into more understandable terms as well.
which is very helpful when you get a scientific article. It's they're sometimes very difficult to read. And I know that in the chat box there, the Reeve Foundation has a resource for self-advocacy, which is very helpful. And also, I'm going to ask Beth to put up the list of people who have all these different companies that are making new nerve stimulators. So Onward Medical makes the ArcEX. SpineX makes a device that is a spine stimulator for children with cerebral palsy, but they're looking at adults with spinal cord injury and other neurological diseases as well in their research. So there's a lot of companies out there. Well, I say a lot. There's like 12 or 13 different companies out there, and there's probably some more that are starting up because this is such a hot topic and people are having success with these. Not everyone, it's not right for everyone, but it's right for a lot of people. And so that is very helpful to get that list of companies, and then you can go in and or you can just ask Chat GPT, Chat whatever it's called. You could just ask them for companies that make spine stimulators, and they'll give you a whole list, and they'll tell you a little something about each one of them. So that's a good way to start, and then you need to do your own investigation on top of that. But there is a question here about the titanium screws and rods, if they're stable for a long time, or do I need to worry about them coming loose?
Most of them are stable for a long time. There is about 5% chance that they could break or come loose. Um, but that's not very, that's not very, it's not uncommon, but it's not likely to happen.
It's not like if you have a broken leg and you have a plate put in to connect the fractures of each end of the bone, and they put screws in a plate in there, and then sometimes you know ahead of time, oh, we have to take those screws out at a later date if they've screwed your bone together. It's not like that process. It's in your vertebrae and it's meant to stay in your vertebrae. So usually they're not taken out. Has been my experience. You might have a different experience, but usually they don't come out. Now, what do you think, Dr. Marco, about the new flexible rods? They're being used a lot, especially in children with spina bifida or with scoliosis. They're putting in these flexible rods with real small incisions at each vertebrae. And then so you have a little bit of movement, but not a lot of flexibility. Do you have any thoughts about those?
For the most part, I would say that that's not the standard for patients who have a traumatic spinal column injury. if it is being used, mm, may have the potential benefits may outweigh the risks, but I did not use them in my practice, and my partners who work at one of the world's busiest trauma centers in the world don't use them.
And would you say that's more for stabilization of the spine? I don't think you would want to use them because you want to stabilize that spine. But if you had a neurological disease, maybe would, something like scoliosis or something that's not impacting the spinal cord, maybe it would be more appropriate at that kind of procedure.
It's possible, even in when we're using rope-like structures in place of the rods to connect the screws. Mm, Even there, we use the titanium rods that are not flexible way, way more. In fact, I would say 999 times out of 1,000, we use the titanium rods, not anything flexible.
Okay, and then once the spine is stabilized with rods, and then you have the vertebrae up above that and the vertebrae below that. Do you see that when you've stabilized, say, three or four vertebrae with a rod, and then does that put more workload on the vertebrae immediately above and or immediately below that stabilization area? Is there any problems with, now the other vertebrae have to kind of overwork to correct because the part of this part of the vertebral bones now have been stabilized and can't have that slight rotation movement.
Yes, it's called the stress riser, those screws and rods in the fused area create more stress just above and just below where they start and stop. And the stress is mostly on the disc and the joints behind the spine, the discs in front of the spine. And there's more stress in those joints and in that disc, which is also a joint. And that could cause or lead to more wear and tear in those joints and disc.
And so then what has to be done if that becomes a health issue?
Sometimes extension of the fusion, usually not, but sometimes extension of the fusion.
Okay. And then somebody wants to know if it's a possibility to take the hardware out after time. And I'm not sure why would you want to take the hardware out? But if after it's been years after your injury, is it possible to remove the hardware?
It is possible. I didn't do that very often in my practice.
Yeah, I don't know why if that's making the correction to stabilize your spine, I don't know why you'd want to take that out. And would it be increase your risk of something more going wrong than leaving it in?
Yes, especially in scoliosis, where that instrumentation, when you do take it out, the bone is alive. It's like a tree, so it could still deform after you take it out. Usually not as much of an in risk of deforming after being fixed for a traumatic injury, but it is more surgery, and if it wasn't necessary, I didn't recommend it.
And then here's a big question. We'll wind up with this one. This is a really big question. Can a T10 cord infarct be reversed? And can a T5 level upper mid chest spine that's been pulled apart or stretched, can that be reversed? So we'll start with the first one. Can a T10 cord infarct be reversed?
I would say any infarct means that it died. So if it died, it probably cannot be reversed. Does that mean that there's not something that could happen and be developed some other time to help dead tissue regenerate? Uh, I think that's within the realm of possibilities. Um, we don't have that technology now, and it hasn't worked in outside of the lab. And so I think that is piggybacking onto the distraction injury in the spinal cord question as well. Can that be reversed? Can that be fixed? Can the function be restored? Not with current research and technology. Hmm. But I always, I always keep in mind what Christopher Reeve taught me is when you choose hope, anything's possible. And so it's been 6 years since my injury, and I've had some improvement in my sensation and some movements. I don't have any functional movement right now. And there's hope. So when at the time of my injury, the ARC-EX system was not out or available or studied, and now it is. And I'm hopeful that when I get to try it, that I will have functional improvement of the returns that I've had. And so I think you never know, and we can always choose hope.
I think you're exactly right. And I um I can almost hear Christopher Reeve's voice coming out of you talking about that because in my personal opinion, he's the one who changed the whole trajectory of uh, curing spinal cord injury and neurological injuries, and looking at the time from him working on his recovery to now and seeing the leaps and bounds that have been made. Do we have the cure? No, we don't have the magical wand waving, oh, you're going to be all better tomorrow cure, but we have a lot of improvements to make life better. If you're interested, if you're happy the way you are, that's fine too. You don't need to, jump on the bandwagon for with all this stuff that's going on, but if you're interested, knowledge is power. And so the more we know, the more we can make good and intelligently informed decisions. And Dr. Marco, I would like to thank you for informing us about what goes on inside the body after surgery because people are always wondering. And I know that, probably people are told, when they woke up from their surgery, maybe they were shown their MRIs. And if you've never seen one before, you don't really know what you're looking at. And so it can be kind of confusing. And, at the time of your injury, post-operative, or if your disease has advanced, these are life-altering upheaval kinds of times in your life. So even if somebody's telling you something about this complex surgery that they did, it's so hard to take it in. So I really appreciate you talking to us today, Dr. Marco, to explain all this to us. And your explanations were so nice and simple for such a complicated surgery, but your expertise is certainly valuable. So I really appreciate you coming on today. And we're going to have you back on again because you're fabulous. And
Oh,
so
thank you.
thank you so much for being on the show with us today.
You're welcome. It's my pleasure.